Good afternoon and welcome to the webinar, Sharing Accountability in the Medical Neighborhood, Multiple Perspectives on Accountable Care. My name is Anshu Chowdhury. I'm a co-chair for the Center for Employer and Purchaser Engagement, the PCPCC. We're pleased to be sponsoring today's program featuring Dr. Kyu Rhee from IBM, Mr. Robert Fortini from Secours Hospital System, and Dr. Carol Henwood, a primary care physician and level 3 patient-centered medical home. I would also like to welcome members of the Specialty Society Insurance Coalition to the call today. This webinar is a collaboration between the Specialty Society Insurance Coalition and the PCPCC. At this time, I'd like to ask John Crosby, Executive Director of the American Osteopathic Association, to welcome members of the SSIC.
Thank you, Ancho, and good afternoon, everyone. Welcome to the SSIC members, physicians, your office staff, and all the organizations who support you. I want to especially thank you for taking this opportunity to learn more about the patient-centered medical home and its great benefits for physicians and patients alike. And congratulations to the SSIC and the PCPCC for collaborating to develop this important webinar. I hope everybody on the call is going to walk away with a greater understanding about the medical home and the medical neighborhood, why it's critical that primary care and specialists work together to advance what I consider a revolutionary model of care. The American Osteopathic Association, my day job, is a founding member of the PCPCC and was one of the 4 original drafters of our joint principles of the PCPCC, along with the AAFP, the ACP, and the AAP. And I'd also like to just comment, we work very closely with the American College of Osteopathic Family Physicians and Carol Henwood, who is one of your speakers today. You're in for a treat. We have invested a lot of time in the PCMH model, patient-centered medical home, for many years. AOA membership numbers approximately 60% primary care and 40% specialists. And given this composition, we appreciate the challenges as well as the importance of primary care and specialists working together to provide comprehensive, complete care to our patients. As we listen to today's 3 speakers, I really want to encourage you to think about the most frequent conditions that primary care physicians refer to you as specialists. What patient information do you need from the primary care physician in order to perform a consult? And what clinical information must you give back to the primary care physicians so that they can manage the ongoing patient care? Please think about these questions, if you would, after we conclude today. Have the discussions with primary care physicians in your neighborhood, your community, and work, as we do, to encourage the formation of medical communities in your community. Thank you very much. Let's have a good webinar.
Thank you, John. Before I introduce our speakers for today, I'd like to take a moment to make a small plug for the Center for Employer and Purchaser Engagement. Our center works to engage employers and purchasers around redesigning benefit programs that incorporate medical home features and innovative payment models. The center also works to share best practices and resources based on successful models, including workplace wellness initiatives, prevention programs, and benefit structures. We typically hold calls 4th Wednesday of the month from 4 to 5 p.m. Eastern, and we're always looking for new members and participants, so feel free to reach out to Tara Hacker or Amy Gibson from the PCPCC if you're interested in gathering more information. So with that, I will begin to introduce our speakers for today. Our first speaker is Dr. Kyu Rhee, who is the Vice President of Integrated Health Services at IBM, where he has direct global responsibilities for health, safety, medical, and health benefits design and strategy services. Prior to joining IBM, Dr. Rhee was the Chief Public Health Officer at the Health Resources and Services Administration, which is the primary federal agency for improving access to healthcare services for people who are uninsured, isolated, or medically vulnerable. Our second speaker today will be Robert Fortini, a pediatric nurse practitioner and the Chief Clinical Officer for Secours Medical Group in Richmond, Virginia. He's responsible for facilitating provider adoption of electronic medical records, coordinating clinical transformation to a patient-centered medical home care delivery model, and facilitating participation in available pay-for-performance initiatives, as well as physician advocacy and affairs. Before coming to Secours, Mr. Fortini served as the Chief Medical Affairs Officer at Queens Long Island Medical Group, engaged in quality and HIT adoption. He successfully applied for the first Level 3 NCQA recognized medical home in the state of New York. Our last speaker today is Dr. Carol Henwood, a board-certified family physician in private practice at Stowe Family Practice Clinic in Stowe, Pennsylvania, which is one of 8 primary care sites of Pottstown Medical Specialists. She's also a staff physician at Pottstown Memorial Medical Center, where she formerly served as chair of the Family Practice Department and coordinator of the Family Practice Residency Program. Dr. Henwood has played an active leadership role within the profession of osteopathic family medicine, serving at both the national and state levels. Before I turn it over to Dr. Rhee for the start of our presentation, just a housekeeping tip here. All presenters are going to be going back to back, so we'll hear all 3 of our presentations, and then we will address questions at the end of the last presentation, Dr. Henwood. There's a question box in the control panel pop-up window, so feel free to enter your question there, and we'll be collecting those over the course of today's webinar, and then we will address them following the presentations. With that, Dr. Rhee, I will turn it over to you.
Thank you so much, Anshu. Can you hear me?
Yep.
Okay, great. I just want to thank you and PCC and the center for inviting me for this, and looking forward to the discussion, the dialogue with my colleagues. So I have the deck up, and I'm going to talk a bit about health at IBM. And as you mentioned, I've been blessed with kind of opportunities working at the federal government and also working in community health centers as a primary care physician. So I know the challenges from a frontline perspective and also from a national perspective, and now a global perspective in terms of the challenges of primary care and building these medical neighborhoods, or if I could even be bold to call them health neighborhoods, if you start to truly think about all the different stakeholders that have an important role in this topic and this issue. So if I go to, let's see, there it goes. Okay, so what I'm going to talk about just briefly is to give framework about how we look at health at IBM, and then to really highlight the importance of primary care and specialty care in what we do at IBM, and how we're looking to influence primary care not only in the U.S., but also globally. And so I'll go into a little detail about what we do at Integrated Health Services. I lead a team of over 300 people globally in a broad range of countries all over the world, physicians, nurses, other health professionals, behavioral health specialists, health benefit specialists, as well as health promotion and wellness folks. And so we've got an extraordinary mission and opportunity to influence the health and well-being of IBMers, nearly 500,000 IBMers globally. And of course, we are concerned about their dependents and the families and the communities in which they're in. So I'll provide some framework of that, and then, so this is the agenda here. If you go to the next slide, this is our vision and mission. And so our vision really is to connect the fact that, that the healthy choices from an individual level to a broader population health level, really population health management is a big responsibility that we have. But we have to connect the choices that people make, making the healthiest choice the easiest choice, the people that we're concerned of, the workplaces in which we want to make those healthiest and safest choices the easiest choice, and then those families and communities, all leading to performance, recognizing really and valuing things like primary care as being a key element of that. And then here you can see sub-bullets as it relates to 5 mission items, and then I'll go into a little depth on the 5th one. And there's a lot more detail. I wanted to provide a high-level overview of health at IBM and how primary care intersects in this presentation, but there is a lot more detail in terms of data, results, analytics, predictive analytics that we're very concerned about in terms of how we look at our population and how we look at the impact of primary care in improving health outcomes, reducing costs, and also promoting and driving innovation. If you go to this slide, this is one of the bullets of the mission, one of the challenges when I came on board about 2 years ago with this look of what are the local and global priorities at IBM, we have extraordinary challenges as a company, and this is just one way to look at the world. This is looking at life expectancy globally, and yeah, as you can see here, in developed countries that spend a lot more in healthcare, those are the ones typically in blue, and then the other colors are typically the ones that are what we would call developing countries or growth market countries. We and other multinationals and large employers are really looking at making the world smaller and having quite a bit of growth in these areas where we know there's extraordinary business opportunities for us. So one of the things that I think is fascinating is to see the challenges as it relates to the conditions that are prevalent in these other countries, and to recognize that primary care is an important piece of the equation for a high-performing healthcare system. And that as we look at some of our spend, some of our investments globally in healthcare, it is fascinating to see how the connection between what we spend versus what we're getting in different countries significantly differs. And I would say one significant variable in that is the primary care system and how effective that system is to really provide, as Dr. Barbara Starfield in her research has shown, higher quality, lower costs, and also equity also is another big piece of the research that she's done in terms of the impact of primary care as you look globally. So thinking about primary care as we address local and global health priorities, it is a cross-cutting issue. If you go to the next slide here, the other important piece, and you know, the nature of primary care, I like to refer to when I was at HHS, we were very focused on primary care with the Affordable Care Act and the impact of primary care. And I'd like to reference the research that refers to the 5 or 6 C's of primary care. The fact that it's about continuity, that you build trust, relationships, that the speed of trust is so important. So when I had patients who I took care of and their families, even though I might only have 10 minutes for that visit, the fact that we knew each other and that there was a trust engaged and there was a continuous relationship was so important in an age where there's so much fragmentation in our healthcare system. So having that continuity is very important. Being comprehensive, and this is the part that I would focus on here, the importance that the majority of your health issues are addressed through your primary care clinician, who plays an important role in assuring that you or your family can get to the right resources and the right help that's needed. And so we at IBM are very concerned about overall health, particularly as we look at the stigmatized and the challenges as it relates to behavioral health, addiction issues, substance abuse, and things of that sort. So the primary care clinician has an important role in that, in thinking about the overall health of our employees and their dependents and their families. The other C's that I like to reference that I really think are becoming more standardized or auditable, partly through efforts like the Joint Principles and NCQA and the different certifications that currently exist, and frankly a lot of what the health plans are trying to do in terms of creating some criteria for primary care. It's coordinated, collaborative, and also the context of community. I think that is one of the great things about having served in Washington, D.C., in those types of underserved settings in community health centers in Columbia Heights. It was clear that the clinician was a significant part of what I was doing in those settings, was recognizing the needs of that community and the resources locally that were beyond healthcare, that recognizing that health is much more than healthcare. So the overall health here is an important piece. If you go to the next slide, which I'll just briefly frame, is that we have to recognize as part of the medical neighborhood, and if you think of a broader health neighborhood, the workplace is an important place. And we in the workplace think very strategically about how we assure whatever we do, whether it's through our work in health risk assessments that typically employers do, whether it's our partnerships that we have, with vendors, we want to get information to the primary care clinician who should be coordinating that care and recognizing the value of health risks as they're identified, whether it's through on-site screenings or biometric testing or the traditional health risk assessment, which about 90% of employers in the U.S. do now, and actually a large majority of employers, as they look multinationally, are thinking about. So one of the things that we have as an initiative now is in the next 3 to 5 years, we expect all of our employees globally and their dependents to have a health risk assessment where one of the factors and one of the questions we'll ask is about whether or not they have a primary care clinician for them and their family. If you go to the next item, and this is one of the fascinating parts of my role, when you see there's so many natural and man-made disasters that go around, and IBMers are in all these different locations, whether they be domestic in the U.S. or globally, whether it's Arab Spring or Thailand flooding or the tsunami and the radiation issues in Japan. I would say that one of the things we're very purposeful about is making sure that part of our investment in our employees and their dependents is in primary care, in what I would call important outpatient coverage and preventive services that assure that access to them in these urgent care situations when they likely will need some additional help and support. And so we do a lot of that on our own with some of our on-site clinics and our more traditional occupational health and safety approaches. But from a benefits design approach, we're also very strategic about thinking about primary care and how we can integrate it into a lot of markets that frankly don't currently value it as much as we believe they should. And that's so the last item here that I'll actually expand a little bit more is how we have this target of health benefits and health promotion programs to demonstrate ROI, to demonstrate that it improves access, increases quality, reduces costs, and drives innovation. And particularly in this field of primary care, I think the evidence is very clear if you look at a lot of the literature that primary care does increase quality and reduce costs. And I do think that what we're doing in PCMH, there's a lot more evidence that's going to come out of this work. But anecdotally, as well as if you look at the broader literature internationally, there's plenty of evidence that shows the impact of primary care on quality, cost, and access, and also equity globally. And so what we've tried to do, and we have these meetings now with each of our health plans this week in the U.S. We have all-day meetings. We are discussing with them their philosophy, their values as it relates to primary care, how it connects to specialists, and how we can drive innovation further as a partner with our health plans. So there are some interesting statistics that we've discovered in some of our research that we're intrigued by. The amount of money that's spent in the U.S. on primary care by visits is typically characterized as about 5%. And we're looking at our own data with the different health plans and seeing that and how that correlates across plans. We're also intrigued with the ratio of primary care to specialist visits. We know, for example, the workforce in the U.S., a third of the workforce is primary care, defined by AHRQ, the Agency for Healthcare Research and Quality. We are intrigued with the distribution and the challenges. And people like Barbara Starfield have spoken that the distribution of the workforce should be closer to 50-50 in terms of specialists in primary care. And as we look at other places where we invest in our employees, we do see different distributions of that. And so we are also intrigued about how, as a self-insured employer in the U.S., how is the ratio of specialist visits to primary care? I think it's another important metric to look at and consider and track. So if you go to the next few slides, I just reference, should have it, this is a recent IOM study that just came out in January. It talks about how we spend so much. This is stuff that everyone knows. We don't get the appropriate value when we compare ourselves to other companies or other countries globally. So we have to increase quality to make people live longer and healthier. Reducing costs. This is a big challenge that we continue to drive and that I'm challenged as managing health benefits globally for IBM spend, which is billions of dollars a year. Looking at Reducing costs, how do we make the pie smaller? And this is currently on the upper left, the pie as it is in the U.S. 30%, 31% is hospitalizations. Frankly, primary care should prevent hospitalizations and an investment in that. 20% is physician kind of visits and the costs of those physician visits. And as I mentioned before, there's been characterizations that about 5% of all healthcare spend is in primary care visits. How do we look at improving upon that? Of course, people know the GDP. We're on a projected trajectory in the next 8 years to be $1 in $5 of the U.S. healthcare of the U.S. spend is in healthcare, which is really unacceptable as the pie continues to get bigger and affects businesses and jobs. And then the lower left, we believe as an employer, a large employer, and as we work with stakeholder groups like this and the PCPCC, it's so important for us to call out that we as folks who are at the table get to decide, hopefully, and get to frame what's on the menu, and we want more primary care on that menu. And of course, folks know how we compare with other OECD countries in terms of our spend, which is really not sustainable. If you go to the next slide, driving innovation, this is a traditional innovation curve. We are looking and we're having some fascinating conversations with the plans as well as partners to look at opportunities to do something that's never been done before in this area and look at data that's so important to help us to track our progress. What you measure determines what you do. And I think in healthcare there's so many measures, and you can have an overwhelming number of measures that you're concerned about, but we are targeting measures focused more on primary care, focused on some of the national accreditations that now have popped up, focused on primary, secondary, and tertiary prevention areas, particularly more in primary and secondary prevention. If you go to the last couple slides here, this is our view of health. This is what we do at IBM. My team globally works on this globally with the managers and the staff, the employees of IBM. But we have these pillars of safety, medical, health benefits, and health promotion. And you can see there primary care and specialty care being highlighted. And we have our 10 foundational cross-cutting principles. But this gives you a little perspective of what we care about as we think about health benefits design in that pillar, but also in health promotion and recognizing we need to start preventing disease and not just chasing our tail and spending 80% of our healthcare costs on 20% of the people who are so chronically ill. We need to figure out ways to prevent that. And we need to be very focused on that and also look at ways to integrate what I would call a little bit more the traditional occupational health and safety pillars, the left two pillars, into the broader scheme of what we do. So things like ergonomics, which we know musculoskeletal issues are so important and such a large cost driver. How do we integrate our safety professionals, our industrial hygienists, to be thinking about that and supporting really the primary care clinician who often is not as familiar with these issues musculoskeletally and how we can address it in the workplace and prevent those things from occurring, things like back pain. If you go to the last slide here, this just frames it according to the different prevention frameworks that we like to think about. People use prevention very, very often. Everything, frankly, in healthcare prevents death. But how do we consider in different tiers the importance of primary prevention, secondary prevention, and tertiary prevention? We in our healthcare system often focus on the tertiary prevention, preventing serious chronic disease complications, preventing death. And a lot of our spend, 80% of our spend, is with that 20% of the population. What we have to do is prevent those 20% of the future, help those folks in the 20%, but prevent the next group that's going to get into that category. And we have to have a very comprehensive strategy that thinks about each of these with strong metrics that are very basic and help drive quality improvement. And as you see here, primary care, we believe, is the foundation of a high-performing health system globally. So that's all I got, and I am now going to hand it off to our next speaker.
Thank you, Dr. Rhee. That was a perfect segue for the story I'm going to tell, and I'm going to, you've given a very nice employer and global perspective for our audience. What I'd like to do is take you down into the weeds a little bit. And actually, I'm going to use a specific case history to illustrate what you just said, that primary care is the basis for effective management of that 20% that drive all the cost. So the first slide you're looking at here should be, very familiar to everyone there. These 6 buckets align very nicely with the 6 major standards outlined in the NCQA application for patient-centered medical home recognition. But they also served Bon Secours as a roadmap for collaborative negotiation with many of our commercial payers. No surprise to us, the NCQA guidelines are the gold standard of care in many ways. So what I'm going to do today is, we all know about access and patient engagement. These are just some of the ways that Secours Medical Group has brought to life these particular standards. Population health. I'd like to talk about registry use a little bit more deeply today. So I'm going to advance this slide here. We'll see if this works. Does not seem to be working. Okay, thank you for doing that. I appreciate that. So this is a case study. let me frame this out for you. We went live with our medical home project at a very large family practice group located in Richmond, Virginia in September. Our project covers all 6 of those areas: the delivery system redesign, documentation tools, patient portal, MyChart access, referral tracking, high-risk reconciliation, and of course registry use. It took us till nearly December to get embedded case management in place in this medical home project model. And so here's this brand new, what we call Nurse Navigator, on the job using a new tool that she had just been schooled on, which is our daily discharge report. And several of our payers provide us with a discharge report, but our own hospital system is all on the same electronic platform, so we're able to, at least from our own facilities, see every patient that is discharged from the ED or the hospital on a daily basis per provider. So her marching orders, this is her 2nd day on the job, was to work the discharge report. And so she ran the report for the physicians that she's supporting, and this patient appeared. Okay, and if you look at this patient, this is a problem list and a medication list. This is a 65-year-old male with multiple comorbidities. This is an uncontrolled diabetic patient who was self-managing himself very, very poorly over the years and progressed to renal disease failure and then heart failure. Okay, so you can see those diagnoses there, and look at all the medications that this gentleman is on. A really impossible task of management. I'm going to go to the next slide here. If you can advance that for me, I'd appreciate it. Great. So what you're looking at here now is in our electronic record a chronologic listing of encounters that this individual has had with the health system. And if you look to the left column, you'll see paper clips. Each one of those paper clips represents an ED visit that ended up being a direct admission to the hospital. Okay, from August 4th of 2012 until December 9th, 2012, this patient had 6 hospitalizations. He was managing himself at home. He was using 911, ambulance transport, and the emergency room to manage his heart failure and his fluid overload. If you look at that encounter list, one thing that should stick out on you is the number of refill requests he's had for all those medications. So he had some type of contact with the practice, but no clear-cut delivery mechanism was in place at the practice before the medical home redesign occurred to effectively, connect those refill requests with visits. You'll see no primary care visits. In fact, if you look back on this particular patient's record, he had no primary care visits in the last 18 months. despite the fact that the recommendation at his last visit was follow up in 6 months. He's been managing himself very ineffectively. Now, you'll notice on December 10th, 2012, this nurse navigator, who was in her role for, again, 2 days, this patient hit her radar screen because of the registry that she was using. So immediately she began to use, if you can advance the slide for me, we'll show you the documentation tool that our navigators use when they're speaking either face-to-face or telephonically with these post-discharge patients. And we're using a very rudimentary predictive modeling tool embedded into the documentation tool. This one is the LACE scoring index. And so depending upon the length of stay in the hospital, the acuity on admission, whether the patient came in through the emergency room or was admitted into the intensive care unit, the comorbidity of the patient, and we have a relatively easy way of just calculating comorbidity, but we prefer that the nurse navigators use the web tool that's listed in blue as a hyperlink in the center of the page. That launches the Charlson Comorbidity Index so that they can understand what the morbidity associated with this patient is. The number of ED visits, so that's the E, this E in LACE, and this patient had at least 4, if not 5, within the last 6 months. And so that then automatically calculates a relative risk of readmission score. And you can see this individual came in at a 12. By the scale on the bottom, that puts him in a high-risk category. You can advance the slide, please, for me. So he clearly meets the criteria for high risk. His LACE score was greater than 11. He fits a lot of the typical characteristics for a high-risk population for readmission: poor support system, male, single, living alone, and poor guy was discharged on a Friday afternoon. The Charlson Comorbidity Scale came in at 10. That's a 50% survival rate with someone with that much multiple comorbidity. And obviously, he wasn't using primary care effectively. He was using emergency room care to manage his illness. So you can very quickly and easily see with this case presentation the cost of that individual's care without a very robust integrated methodology of access to primary care. And we really believe that the registry use is just one part of that, one of those tools that allow us to route people into primary care services more effectively. If you go to the next slide. Thank you. And I'm going to end with this slide because I don't know about the rest of you, but I'm looking forward to hearing Dr. Henwood speak. But what you're looking at here, and I don't think you could see it all the way to the bottom, but it doesn't matter. The message is very simple. That simple strategy of outreach to a patient within 24 to 48 hours of discharge and routing them into primary care, med reconciliation, red flag rehearsal, discharge instruction reinforcement, and scheduling them for a visit with their PCP within 5 to 7 days of discharge is effectively managing 30-day readmission rates. Our 30-day readmission rates for the cohort of patients that we're capturing in this PCP-assigned registry is running around 2% or less. And when you compare that to larger all-cause universal readmission rates, that's extremely successful. So with that, I'm going to segue to Dr. Henwood, and thank you for the opportunity to present this case.
Thank you for advancing the slide. Good afternoon, everyone. It is my pleasure to join with you today with my perspective is on collaboration between the patient-centered medical home and medical specialists. As previously stated, I am a family physician in southeastern Pennsylvania. I am one of 8 primary care Level 3 recognized NCQA medical homes in a physician-owned group that cares for about 160,000 primary care lives. I also am the Vice President of the American College of Osteopathic Family Physicians, whose strategic initiative recently has been to provide resources for our members and for non-members alike to become patient-centered medical homes, because we believe that the patient-centered medical home concept is the healthcare delivery system of the future, and certainly all the stakeholders in the patient-centered primary care collaborative, I believe, hold those same tenets to be true. So if we talk about the triple aim of our new healthcare transformation, and I almost always never say reform because that has a negative connotation, but especially the Affordable Care Act, that we're looking in the United States to have improved health and enhanced patient experience of care and reduce cost. And so if you read about the triple aim, this is what it means. The triple aim plus one, which is, you see at the bottom of the scale, is improved productivity, really smacks in the face of the new mandate that everyone will have health care insurance. And there have been some pushback from small businesses saying, you know, I can't afford the health care insurance for all of my employees, and maybe I'll just pay the penalty. Well, one of some of the research that was done actually by stakeholders in the Patient-Centered Primary Care Collaborative a couple of years ago actually demonstrated that it actually would cost as much as 3 times the dollars that you would an employer may have to pay for their employees to have insurance in poorly productive patient on the job. A diabetic whose insurance or whose blood sugar, excuse me, is not well controlled is not going to do the same job as someone who is, and the amount of sick time, et cetera. So again, our aim is really the triple aim plus one, and having people that are healthy and employed, and that's what back to some of the comments of our IBM person. So what I'd like to do is spend some time talking to you a little bit about what is the medical home, but more importantly about how a medical home works. And I'll show you some of the care coordination things we do and have some suggestions on how we can expand those into the non-primary care specialists. So one of my fondest things is to say that I am a primary care specialist, and it's my honor and privilege to work with non-primary care specialists, but we all are specialists in the practice of medicine. So the patient-centered medical home is a means of coordinating care. There's no doubt that coordination of care leads to quality, and quality is the pathway to affordability. And I think that's where we're all headed in trying to transform our healthcare system. Then you'll see in front of you is our version of the medical home team. So every patient who's new to Pottstown Medical Specialists or Stowe Family Practice actually gets a handout that talks to them about the benefits of seeing a primary care provider who is part of a medical home. And you can see that this team is patient-centered and team-based. So this is the entire people that work for us. So the issue is that each of these people in the medical home team has a defined job description where they are held accountable as part of the team for what they are supposed to do. And I'll give you some examples of some of the job descriptions. But it also affords the patient to have multiple relationships. And so they will feel free to reach out to the various members of the medical home team, and together we provide a high-quality, cost-effective care. So if you just talk about the patient educator, who in most cases has to do with diabetic education, since that one is one of the most expensive chronic care conditions that we have. So, for example, I make a diagnosis of diabetes for a new patient, and instead of just saying, here's a meter, here's your diet, take your pills, and I'll see you in 3 months, we refer the patient to the diabetic education or the patient education team. And so in addition to one-on-one and group education, the patient also has a touch to the diabetic educator and is instructed to call the diabetic educator weekly, say with their blood sugars, or if they're having trouble with their meter. And so rather than a touch for 3 months later when I might see them back in the office, they've had it multiple touches. And so we see improvement in the hemoglobin A1C, which is the 3-month diabetic blood sugar average. And so, as I said, it gives the patient multiple care opportunities. The gentleman before me was speaking about care coordination after the hospital, and either the care coordinator or, in my office, one of our medical assistants is responsible for calling all patients that are discharged from the emergency room or the hospital the very next day to talk about meta-reconciliation, to talk about can they help with scheduling the follow-up orthopedic care or the follow-up cardiology care that the patient might need. Or if there's a question on the medications, they'll refer that then to the primary RN or advice nurse that's in the office that can talk about any of the problems they might have. One of my favorite examples is the patient goes into the hospital and the transition of their statin is to the formulary of the hospital. The patient is discharged and gets a prescription that's written for the statin of formulary and goes home and proceeds to take both their outpatient statin and their inpatient statin. And if no one knows about that in a very short period of time, then the patient is readmitted or has a significant adverse reaction just because the care wasn't coordinated. So those are just some examples. We also have a referral specialist. So any prior authorizations or any testing that perhaps is ordered by our non-primary care specialist can be authorized and handled, and so that the care is the right care at the right time is afforded to our patients. All of the members of the medical home team, though, including the patient, possess accountability, and that's a question that when I speak about the patient-centered medical home that's often raised is, where's the patient's role in this? And the idea, if the patient, and Barbara Starfield was mentioned a couple of times, that was one of her big keys, is that if something that's patient-centered will increase patient engagement and allow that patient to, say for diabetes, stick to their diabetic diet, to for congestive heart failure, stick to their low-salt diet, to not have a problem with medication compliance, do the exercise regularly. So if everybody, all team members of the medical home, and I'll talk about how we can expand this to the medical neighborhood in a few minutes, but all of these will lead to enhanced patient experience of care, which then leads to more affordability, et cetera. So at last pass, approximately 34% of the primary care practices in the United States were recognized as patient-centered medical homes. And to quote Dr. Paul Grundy at a recent patient-centered primary care collaborative meeting, he stood up and announced, and very jubilantly, we're all very excited that we feel that we're past the tipping point, that we have enough primary care practices that have become medical homes that have said to us that this will be the primary care delivery model of the future. However, we need to provide resources to those physician practices, especially the smaller physician practices, to become medical homes. We know that there's a primary care shortage, and depending on who you read, can be as much as needing 20,000 primary care providers by 2020. But there are still large numbers of physicians that practice in 2 to 5 or less physician practices. And from an organizational medicine standpoint, especially from the ACOFP, we feel that we cannot allow one physician to stop practicing medicine because they feel they can't do it or they don't know how to do it. And so, again, organizational medicine's responsibility is to provide those resources. So let me talk to you a little bit about what some of our coordination efforts are. So for those of you on the Specialist Society side, and you'll see when I get to my comments about how we can expand this, I think some of the issues is you don't know what we do. And so let me talk about a couple of these things. So one of the things we take very seriously at Pasta Medical Specialists is completion of tasks on time. So task is the equivalent of electronic sticky that something needs to be done, such as a medical complaint callback or a medication renewal or a follow-up call from the advice nurse, say, between the provider and the patient. And we delineate the task on time's urgency as urgent, which will be completed with 1 hour, ASAP, which can be repeated, which will be completed within 4 hours, or routine, which will be completed, within 24 hours. So when we talk about patients going to the emergency room and access to care, one of the things that we know is that if the patient calls the office and does not receive a response within a certain period of time, that can prompt them to present to the emergency room. And the latest statistics that I'm aware of, between 1996 and 2006, 47% of the emergency room visits could have been seen in the primary care office. So the patient calls my office, for an example, talking about they might think they have chest pain, and if someone doesn't act on that chest pain, and they perceive that it's an emergency, they will likely present to the emergency room. Or if, for example, they don't perceive it as an emergency and don't hear, they could have an untoward event. For example, myocardial infarction or pulmonary embolism, and then the cost of care goes much higher. And so med renewal is another thing we do. If someone is calling, they need a medication, we follow up with them. Or if, for example, an INR comes, which is for Coumadin use, comes to my electronic record, that comes in an urgent fashion, and perhaps it's not at goal, either too high or too low. It's important that we get back to the patient, again, via the advice nurse in a short period of time. So the goal for Pottstown Medical Specialists is that all tasks on time, whether they be urgent, ASAP, or routine, are completed at 80%. And I'll show you a couple of examples that have some specific slides after I get through this particular slide. But we look monthly over what percentage of tasks on time are completed, and then work to make sure that the next month the percentage meets the 80% goal. And so looking back at what happens, perhaps the advice nurse has too many tasks to complete, or perhaps the front desk didn't put it in the proper task bin, are reasons why things don't get complete. You can also use your electronic medical record to identify patients that need increased services. So one of the reports that's run monthly in my office is the list of diabetics whose hemoglobin A1C is greater than 7.0. And that list then is sent to the diabetic educator and care coordinator to reach out to the patient saying, you know, are you having issues? Is it that you can't afford your medication? Is it that you're in the donut hole? Is it that your meter is broken? Is it that you don't have test strips? It also allows us to afford the increased technology. For example, a 3-day continuous glucose monitor that will allow us to say when are the blood sugars the highest. And so, and I'll show you an example of that how we can track who are those and who has indeed had the iPro, which is the continuous glucose monitor product that we use. We also run monthly reports on test tracking, which is something that shows that if the patient had a test ordered, a blood sugar, a chest x-ray, a mammogram, and that test was not completed within 30 days after the date it was due, a monthly report is generated. And one of the medical assistants is charged with working that report and contacting the patient. Why, Mrs. Jones, did you not have your mammogram done? Oh, my mother was sick, or I was sick, and I had to reschedule. I lost my order. And so someone else is reaching out to the patient saying, here, let me send another order. Let me help you schedule the appointment. We do the same thing for referral tracking for those patients referred to specialists who were not getting a report back from the specialist. Was it that the specialist forgot to send us the report, or was it that the patient did not keep that appointment, even though we may have scheduled it for them? And so, again, once a month, the referral tracking report is worked. The patient is contacted, and then if the patient's name appears again the second month, then I'm contacting the patient. So not only did my staff contact the patient, then I'm contacting the patient. Some other reasons why referrals may not have been completed, for example, a patient changes their insurance and now they have a high deductible plan and they can't afford the colonoscopy copay. Well, I may not have given them their 3 hemocults at that visit because I assumed they were going to the specialist, and so that would be a time to send them the hemocults so that colorectal cancer screening does not fall through the cracks. We also do patient satisfaction surveys, and we talked about enhanced a patient experience of care, and I'll show you a few things about how we do that and why we are looking at how we can become better primary care providers. And we also have a patient advisory council, which is a representative from one representative from each of the primary care sites who meet 3 times a year to talk about things like medication safety. How can they give input that we can help our patients with medication safety? We have a monthly newsletter, and we ask their opinion on, is this understandable for you? I mean, I review it, and the woman who writes it has a degree in marketing, but do the patients understand what we're saying? So those are some of our coordination efforts. Let me show you a couple of examples here. So if you see, this happens to be me. This is the callbacks. This is the follow-up calls. And the total, this was when we just got started about this a few months ago, and we were able to say that 75% of the tasks were on time. If you go to the next month, then you could see that 86% of the tasks were on time. And the way that we looked at that is by figuring out why were some of these things not handled on time, and who needed to do their job better, who needed to be more accountable in the primary care team. This is the example of the report that I showed you that says the hemoglobin A1Cs, and then you can see who had the iPros on their particular day. We also talk about who had their LDLs that were potentially not at goal and who was not on aspirin therapy. So this report that we run monthly gives us a lot of information. This is an example of looking at our access to care, and we do an electronic survey quarterly, and this is the most recent ones. You know, how many and how in the past 12 months, how many days did you have to wait for an appointment when you needed it? And so same-day access, again, decreases that amount of time, or that likelihood, excuse me, that the patient is going to go to the emergency room. And this is one about how many, was the staff courteous and respectful to you? Because we need patients to be engaged and not feel that they can't call the office. So accountability in the medical neighborhood. So we have all these great things in the patient-centered medical home that is largely directed at primary care, but we know that we need to work together, the non-primary care specialists and the primary care specialists alike. And as we expand from the patient-centered medical home to the patient-centered medical neighborhood, you know, how can we work with this? Well, these are some of my thoughts on the barriers, and I think the biggest one is primary care, non-primary care specialists really don't know about the medical home and don't know what we do and don't know why it's important that we get the correspondence back so that we can make sure that we have coordinated their care. On the other hand, I neglected to say that it is also important when I'm referring a patient, say, for example, to the ophthalmologist, that when I send that referral, I'm also sending what is their hemoglobin A1C, so that the ophthalmologist knows, gee, this patient might be more at risk for the diabetic retinopathy, or the same thing goes to the podiatrist that they're seeing, so they might be at more risk to have more of the complications of the diabetic foot. The second barrier really is electronic medical record interoperability. I have, in addition to the 8 primary care sites of the PatientCentered medical specialists, we also have an internal medicine subspecialist. So it's easy for me to send an electronic text saying to the cardiologist, patient is coming to you for chest pain, see their my recent note, and you can see that he has the opportunity to look at all of the recent testing, so that the amount of duplicate testing is cut down. But again, the smaller practices, or where there's not a large group of non-primary care specialists associated with specialists, it's ever important that we send the information, because you know, the cardiologist will say to the patient, well, when was your last stress test? Well, the patient says, well, I'm not sure, not all that long ago, but you know, the patient might either need one or not need one. If the cardiologist doesn't have that information, then there's a greater likelihood that there will be duplicate testing. And probably the most difficult thing is the lack of widely accepted evidence-based guidelines across all specialties. So diabetes and hypertension and coronary artery disease are widely accepted, but in some of the other specialties there may not be. And so I think that organizational medicine again needs to help with the definition of what these evidence-based guidelines are, so that everybody has the knowledge about what the highest quality, cost-effective ways of practicing medicine there are. So the solution, I believe, and this is purely my take on this, is that it's only partly a financial issue, both on the primary care end and the non-primary care end. In mature primary or patient-centered medical home markets like the one that I practice in, we have enhanced reimbursement just for becoming recognized as an NCQA medical home. But I think it's more than that. It's not just become a medical home and make more money. In the accountable care organizations, the ACOs, everybody will have the opportunity to share in those cost savings. But I think physicians in general, if they're given the opportunity to work together, they will, because they want to do what's best for their patients across the board. I think that we need to develop a culture of quality reporting, again, both on the primary care side and the non-primary care side. And it's known that continuous quality assessment leads to quality improvement. And a couple of the examples that I just shared with you, specifically the task on time or the referral tracking or patient satisfaction, the more we look at what we do, the more accountable we hold ourselves as well as the patient, the better off that we're going to be as a health system. We need to share best practices, and so in calls like this where there's education and sharing, but also sharing between larger groups who may be recognized as medical homes to those that are still in that process, the sharing of best practices. There's no need to reinvent the wheel, and what will work will in one group will hopefully will work in another, or doing sharing of staff. For example, in a group of small practices that are not necessarily linked financially, they could certainly share a diabetic educator or share a care coordinator, because those are certainly expenses that maybe a smaller practice might not be able to handle. And then last but not least, I think we need physician motivation for quality improvement. And the best way that I found is to give the person their quality numbers, and they will hopefully work to become a better physician, a better part of the healthcare team, to better engage their patients. And so I've been in practice 28 years now, and I'm fond of saying that I've never been more excited about getting up and going to work in the day and becoming part of a better healthcare system in the United States. And that concludes my presentation.
Thank you to all of our speakers for wonderful presentations, very informative and insightful. We do have a few questions that have come in through the online chat box, and I encourage others, if you have questions that you'd like to ask our speakers, send them in the pop-up box in your control panel, and we will relay them to those on the call today. The first question that we have, and Dr. Henwood, I believe this is directed to you during your presentation. It was mentioned that a readmission rate of less than 5% is considered exceptional. What is the generally known average readmission rate, and what is considered acceptable versus unacceptable? Where is the line drawn?
That was in Mr. Fortini's presentation, but I believe that our group, we are looking to get our readmission rate under 15%. I think it's significantly higher. It's close to 30 to 40% nationally, but perhaps Mr. Fortini can speak to that.
Sure. That's not an easy question to answer, because you have to keep in mind that the cohort of patients that are included in this reporting have assigned the primary care providers to start with. Of course, there is that case study that I showed that not everybody is compliant with regular visits to their primary. But I'll tell you, and again, not understanding the framework that Dr. Henwood just quoted, I know that the average all-cause generic readmission rate in Virginia runs 8 to 10%. Now, that's much higher when you get into certain disease categories and in Medicare population. But 8 to 10% is what we're comparing our accomplishments to. Our facilities, we have 7 hospitals in Virginia, run from 5 to 11%. The medical group, and these assigned patients, we're running less than 2%. So we're outpacing them.
Thank you. Another question, and this one actually is for Dr. Henwood. How are the PCPs paid in your practice setting? Production, are they salary, based on performance metrics? The challenge that this individual is mentioning is that while implementing the PCMH, we're still in the fee-for-service productivity payment model, and administration is reluctant to pursue the medical home due to higher staffing costs and potential reduced productivity. Do you have any advice?
Certainly. First of all, there are, as I said, more mature and not as much mature patient-centered medical home markets. So in southeastern Pennsylvania, we, for one of our largest carriers, Independence Blue Cross, are paid in their managed care product, which is Keystone. Either it has a Medicare and a commercial. We are paid $1.25 per member per month if your practice is recognized as a patient-centered medical home. $2 if level 1, excuse me. $2 if it's a level 2, and $3 if it's a level 3. And you also have the opportunity to share in the cost savings compared to your peers for both the $4 in the commercial side and $8 in the Medicare side. So there is some payment just for recognition as patient-centered medical homes. Our reimbursement model has to do with a base salary. The patient-centered medical home dollars are put on top of that, and there is somewhat of a productivity across all payers bonus that you're eligible for. I think that when it comes to productivity based on becoming a medical home, and is there higher staffing costs and lower physician productivity, what I found in my particular practice is we do a lot of job sharing. So while you see that patient-centered medical home team, for example, the secondary MA is the one that's responsible for calling the patients back. And we actually found that we did not, from office site to office site, have to increase staffing. We just did a lot. We did a lot of job sharing and held those people accountable. In our system, we share the diabetic educator and we share the care coordinator, and perhaps I should have been more clear about that. But the rest of them are at each particular site. When people ask me, do you still see the same number of patients a day, and I say I do, but I take care of them better than I used to because of the way that the patient-centered medical home team works. So in the beginning, there may be some decreased productivity that comes to getting your medical home team up and running, but at the end of the day, people are healthier and we are taking care of them better than we ever did. So I would encourage the your health system to pursue that, and especially if we do move to the accountable care organization model as the next step, the people are going to be reimbursed on not only the quality metrics that they've attained, but also on the cost savings that they're contributing to, and it will be important for health systems across the country.
Anshu, this is Robert Fortini. If I can add on to that, that's a question we get asked all the time, and my job as an operations person is to make the business case for the medical home model and the increased FTE allowance at the practice level because of like embedded case management, for example. And just to elaborate on what Dr. Henwood has referred to, you know, I think productivity at least stays the same, if not goes up, because many of the menial or simple tasks that formerly fell to a physician go to the care team members now. And that frees the physician up to do more complex tasks and to use their medical degree more effectively and efficiently. So that's one. Two, payment reform, and Dr. Henwood referred to the PM adjustment that comes with NCQA recognition. We have signed contracts with 4 of our payers, including our largest payer, which is Anthem in Virginia. It represents 125,000 lives to us. They have been giving us a care coordination fee for providing, you know, RN care coordination, registry reviews, and all the other tenets of a medical home practice. In addition to that, there's a quality incentive bonus that we're eligible for in that contract. And it's easier to hit those quality metrics, whether they're meaningful use or HEDIS, when you have an energized, engaged team of people facilitating the physician delivery of that type of comprehensive care. We were just awarded recently one of the CMMI MSSP grants. We're Medicare Shared Savings Program awardee. So we've got an ACO in place, and believe me, with fee-for-service Medicare, embedded case management and medical home care delivery system is going to be integral to realize those shared savings in that initiative. That represents a tremendous amount of money for both the physicians who are involved and the hospitals now that are, you know, experiencing decreased ED utilization, length of stay, 30-day readmissions, and avoidable admissions. So it's keeping them whole. I might back up and add that with Anthem and also with Cigna, there's gain sharing in those contracts. So in year 2 and 3, we also profit from the total cost of care reduction around utilization metrics that they've established. And those utilization metrics run from everything from generic drug utilization to the ED visits and 30-day readmission rates, as you might well expect. And then the final ROI that I can argue for with medical home model is downside risk reduction in value-based purchasing. All hospital systems across our country, well, not all, but many, have suffered from DRG reimbursement reduction because of the inability to hit thresholds around CHF, AMI, and pneumonia. And believe me, in our medical home practices, where we're doing registry use for heart failure, for diabetes, for CAD patients, for recently discharged patients, we're showing remarkable improvement in 30-day readmission rates. So that's reducing the downside risk for our hospital system. And again, as far as physician compensation models, we're in a base plus production model right now. We have 450 employed physicians across the Commonwealth of Virginia, and we are escalating a conversation and soon to articulate a compensation model that is more in alignment with what health systems like Geisinger are doing, where there's a base salary, production, and then a quality incentive around certain domains of care, total cost of care, utilization, quality metrics, so on and so forth. So that's the business case that I make for medical home on a daily basis.
Thank you very much. Dr. Rhee, this question is for you, actually a question and then a follow-up. You mentioned that 5% of total spend on primary care for your employees. What's the average, and does it vary by plan, by region, and how do you compare that?
Yeah, so I think that's a good number. We range around 5%. Actually, nationally, that is the average, 5%. This is Bob Phillips from the American Academy of Family Practice. We've talked with him on a number of topics, and he's been a great expert as it relates to primary care. But he characterizes that the challenge that we have is, frankly, the pie is big. The pie is big enough in our country. And employers, frankly, are paying for that pie, whether it's through the taxes related to Medicaid and Medicare, or it's related to employer-based insurance. So Bob has said, and it said that we need to double down and get it to 10 to 15%, is what he said. And so there is variation. We've looked at our plans. There has been some variability. I think the other ratio that's sort of interesting, which I reference, is the ratio specialist to primary care. And this is where we need some consistency, in my opinion, on how we define primary care. I think when I was in HHS, and I mean, I had different groups talking to us and saying that they were primary care. The ER docs were saying they were doing primary care. In many ways, they were performing primary care in some parts of it, but that's obviously not what we want. There are certain specialties we look to, and the CMS definition, I think, for the PCIP is one thing that we're looking strongly at right now at IBM, which defines it in the categories of medicine, peds, geriatrics, and family practice, and includes nurse practitioners and PAs and clinical nurse specialists, I think. And so we're looking at that, and not hospitalists or ER docs who happen to be one of those specialties is another provision of that definition. And the third part of the definition is the actual setting in which the care is delivered. So we were very proud in 2010. We provide no cost sharing for primary care visits, and we're looking at refining it as some aspects of the Affordable Care Act have made some changes, and we're looking at the impact of that no cost sharing for primary care visits on quality and cost. And we hope to publish something probably in about a year on that with the Employee Benefits Research Institute.
Oh,
but
great.
the simple answer is it would be great to double down and get it to 10%.
Okay, well, thank you. And you actually started to answer the second question that we have for you, was how are you engaging your employees in the medical home? So is it active recruitment? Is it through benefit design? And do they understand the value? So you mentioned the cost sharing and the for primary care visits. Are there other ways that you're actively engaging your employee population in seeking out?
Yeah, I think it's a total strategy. It's a total population health management strategy. Employers are paying the bill. If you were going to a restaurant, if you were buying a house, you would make sure that all the aspects of the house are sound, and we think primary care is a big part of that. And we need experts to help us on that, and we have a broad range of partners and experts, and we look for health plans that will innovate with us. So I think part of it is thinking and recognizing that employers do foot a lot of this bill in terms of healthcare, and we look at the benefits design, frankly, and a lot of times the designs that we're given don't have good centerpieces for primary care and prevention, and those are things we ask them to customize for us, not only in the U.S. but globally more. We're looking at, so that's one piece. I think as you have services, as you have clinicians, as you have team members like we do who are professionals who work for the company, we make sure that they're connecting folks to their primary care clinicians, and it's an integrated approach. As we have clinics, we run about 60 clinics globally in different settings in different countries, and we try to challenge those folks to be thinking about connecting with primary care. I also think it's about helping the primary care clinician on what we know causes these chronic diseases, which clinicians often focus on for early detection or disease management. The basics of physical activity, nutrition, stress, sleep, those are in many ways, and smoking, the different alcohol and smoking. Those are the basics. I frankly don't think as a healthcare professional we're very good at knowing how to handle those issues, and I do think this is an area of extraordinary innovation amongst employers who try to do some very creative initiatives. And now with the Affordable Care Act that has a 30 to 50% wellness incentive aspect to it, I think there's going to be a lot more innovation in this space, and frankly I hope that the healthcare system and primary care clinicians will continue to contribute to that.
Thank you. this question, the next question that we have here, so a large percentage of patients that this individual is seeing are on 3 or more anxiolytic/antidepressant drugs, some taking 6 or more different medications in these categories. Does the PCMH community recognize this problem, and how will it be addressed? This individual has encountered patients who've been able to come off certain medications after undertaking a lifestyle change, but are there specific programs underway through the medical home concept designed to increase patient responsibilities for their own welfare?
I can make some comment on that. First of all, in the patient-centered medical neighborhood, the people that we want to extend quality reporting and quality guidelines to are pharmacists, mental health workers, the visiting nurse, the expansion to the other caretakers into the medical neighborhood. I think that mental health services nationally need beefing up, for want of a better word, where patients need more access to that. And so we hope to partner with psychologists, psychiatrists, and in some, again, very mature medical homes, the psychologist sees the patient at the same time as the primary care clinician to talk about social issues and those kind of issues. So that if we can handle whether it's caretaker burnout or financial stresses or whatever that might be contributing to taking this kind of medication. You're right, lifestyle changes are a great part of it. I think trying to get to some solutions over why you might need this many medications in this particular family is part of the answer, but then medication compliance across the board, whether it's your diabetic medications, or trying to become just generally healthy. But I hope, and that we're, not that I hope, I think that there are times if you don't have a whole team, it's easier to maybe add a medication versus having the resources to work with the patient to get at the root of the problem. But a patient has to be buying into this. They just can't be coming to their provider saying, "This is not working. I need something stronger, or I need something else." We have to all work together to handle this situation.
So this is Robert Fortini, and absolutely, Dr. Henwood, you hit the nail on the head. Using the different disciplines in the care team and skill sets more effectively really assist with engaging patient compliance and buy-in. So we have a PharmD as part of our medical home team, and she is a resident at the VCU residency pharmacy program as well. I mean, she's faculty rather. So she comes with 3 residents who participate in our medical home initiatives, and they regularly see patients on a schedule that will have polypharmacy in our medical home practices. And specifically, they focus about 50% of their time in our senior care medical home, which is aimed at a geriatric population. As you well might imagine, that's where most of the polypharmacy occurs. And just doing simple things around medication reconciliation so people aren't duplicative in therapy and understand side effects and dosage and administration helps to clear up a lot of the confusion. But many times what they do is in the process of that meta-adherence and reconciliation, they will identify opportunities to streamline medication regimen, and they will make recommendations back to the primary care physician, who is the team lead. This is they suggest this agent over this agent, so it's a bidirectional flow of information. It's very effective. The PharmD's engagement in the medical home has been so effective, that we've scaled the program up and are intending to hire more of them, particularly since we've found that with some of the preventative services that Medicare now covers can be delivered by other members of the team, like a PharmD, for example. That's just a little value added for the organization as well as the patient.
This is Kyu. Just quickly, I reflected as a primary care physician serving in underserved DC. at Upper Cardozo, and I just went over there recently and saw my colleagues, some of who I recruited over there, still practicing there. I was very impressed with the fact that, I mean, we've transitioned quite a bit. I have to tell you, that health center was focused. We split things up: adult medicine, pediatric medicine, behavioral health. We had kind of, as part of the transformation that we did, was we created teams, we created pods that integrated behavioral health clinicians, and also social workers, and even pharmacists as part of the team. So recognizing that part of the challenge that we have is health is a team sport, and that often we're not trained that way. We're trained in our unidisciplinary approach, and then we're expected to practice on people, with people, and on hearts and lungs, and help folks when we're sort of got a little bit of that training on the job, but a lot of times we were very unidisciplinary focused. So being transdisciplinary, being supportive of each other, thinking of innovations like you were just mentioning about integrating the pharmacists, integrating the behavioral health folks, addiction specialists, et cetera, so that we're supporting the primary care clinician, who frankly is extraordinarily overwhelmed, especially now with this increasing influx that's going to come with increasing coverage. And the fact that we don't have enough primary care clinicians, we have to really be thinking from a team-based approach, is what I reflect on. In my current role, I reflect on it a little differently, because as an employer who purchases care, and 25% of our healthcare costs are related to medications, and we can see the number of meds that are related to mental health and behavioral health issues. And we do look at partnerships, for example, with CVS, and look at strategically how we can look at the measures that really are important, connect those measures of claims to risks, like our health risk assessment tools, which has aspects of medication adherence issues and behavioral health questions, and how we can also connect those risks to claims to performance, and recognize that health is much more than what I got trained as a physician in, which is just kind of pathophysiology of disease, but the other aspects of health, which are much more holistic and emotional, mental, and even social. I think that's another key piece that I've started to learn and recognize, that there is like a vital sign of social connectedness, and folks who don't have that, frankly, are at much higher risk of behavioral health issues.
Thank you. We're running up on about 5 minutes left in the webinar, and we still have a number of questions we haven't been able to get to. So for those who do not hear their questions being called out, I imagine if it's okay, our speakers would be happy to offline for you to reach out to them directly and potentially get some answers to your questions. One question that I would like to ask is, it's a combination of a number of questions that I've received here about the role of the specialist in the medical home. So, how do we, and this is to the entire panel, how do we create an incentive for specialists to participate in the medical home? Communication with specialists, are there templates being used by primary care practices as far as medical neighbors sort of arrangements or formal compacts with those specialists? And is there a role for enhanced primary care that incorporates specialties into the medical home? And for example, a psychiatrist in a primary care setting, or a specialist in psychiatry, or a primary care specialist. What are the different ways that we can bring the specialties into the medical home, communicate with them more effectively from the primary care side, and create the incentives for the medical neighborhood to function effectively?
I can start if you'd like. There are some templates. If you're using electronic medical record, there's some meaningful use criteria that has to do with sending the meaningful use summary to when a referral is made to an outside specialist. So there are some templates that are related to that. I think it's an awareness that they function better if they know what I know, and I function better if I know what they know, and the patient does better if we're all talking. So that always some kind of communication back and forth. The idea of actually specialists like the psychiatrist, usually that's a matter of accessibility to some of, especially mental health specialists. But I would say the offices without walls concept that you could certainly share. A pharmacist, again, some research that was presented believe the military said that they're incorporating one PhD pharmacist for 750 active service, 7,500, active service persons, or that you need a care coordinator for 2,500 chronic care folks, where that's some of the research that's been presented. So the idea of groups, whether primary care or non-primary care, are banding together to get those services that are be available. And I think if once you are in an experience where you know how well it works once you're doing it, that only creates you incentive to do more and more.
Oh, this is Kyu from IBM. I think a lot of what's challenging, if there's one word I like to call what our healthcare system is, it's fragmented, and we need basically integration. We need to kind of be on the same page, and there's so much data in healthcare, there's so much information, and there's not really, so part of, I think, building relationships, when I think about it, frankly, I think about a primary care clinician ideally in a medical home is kind of in the center with the patient or that family in a family-centered approach, and then around their spokes, which include specialists who are an important part of the team. And we also have pharmacists, as we just mentioned, in terms of medication adherence or behavioral health folks. There's a broad range of disciplines that have to work together in that medical home. And you need to share data together. And I remember when I started as the medical director in a community health center, one of the first things I said is, let's use the same chart. We had all these different sections. The charts were in separate places, and people who were doing behavioral health were using their part of the chart, and other folks were using other parts. And people didn't see it. They didn't usually go into other parts of the chart, the paper chart at that time. And so we try to make it so that we all used the common chart and we saw what each other wrote, and that had to build trust. So similarly with IT now and health records, there's going to need to be better integration and trust and sharing of information across specialists and primary care clinicians. So I think that's part of it. I do think as we look broader, and I keep emphasizing this, employers are overwhelmed. We're all overwhelmed in the U.S., but the pie keeps getting bigger. We can't continue to sustain this belief that every year healthcare costs can go up 7%. We have enough money in the system. We have to start making some hard decisions and have the courage to recognize that we've got a significant amount of waste. We've got a significant amount of challenges to promote what I would call efficient care, and primary care needs to be the foundation of that. And big part of the challenge is we are looking at more of the data analytics. We talk about preventable hospitalizations, yes. Preventable ER visits, yes. But I would argue there's also an aspect of preventable specialist visits, and we have to start thinking about that and see the impact that that has on health. And so there are a lot of employers that are looking at specialty networks that will be looked at and assessed based on quality and cost. I mean, I just was in a meeting yesterday, with one of the major health plans, and they were talking about how they were looking at their data, and they had specialists who were basically doing double endoscopies annually, and they were also not doing it the same visit. They were doing 2 separate visits. And, you know, those types of things we have to confront and address, and those are costs that we're all enduring that are not really acceptable. So there's a lot of room to look at efficiencies, I would say, and partnering primary care and specialty care, building trust, but also really changing some of the current fragmentation we have.
Thank you very much. We are at the end of our time here, and thank you to all of our speakers today for an excellent presentation. We had a number of questions that we weren't able to get to in our time today, but if anyone would like to do any follow-up with our speakers, please feel free to reach out to them directly or send them through the PCPCC to Amy Gibson, and she can make sure that the questions get funneled to the appropriate contact. Thanks again for participating today. I'd like to thank the SSIC for joining us, and everyone else that was on the call. We appreciated your time and your contributions. And Amy, any other closing thoughts? Okay. Well, we'll close out here now. Thank you very much.
Thank you.